Hello everyone. This is going to be a brief session with some spotlights on some important pharmacokinetic calculations. So as a physician, why do you need to know about pharmacokinetics? Why? Because if you want to have an effect of a drug on whatever disease, if you want to achieve any drug effect, you need to achieve a plasma concentration of that drug in the blood, and you need to maintain that concentration. So this drug concentration, this plasma concentration, is very important for you because it is this concentration which is going to perform or is going to bring about the good action or the therapeutic action that you need to see on your patient. So you need to achieve this concentration in plasma, and you need to maintain this concentration in plasma for as long as you want this drug to be active. So pharmacokinetics is really a big science, and you are of course aware about three important kinetic processes, which are absorption, distribution, metabolism, and elimination. However, this session is going to be very much focused to answer or to achieve certain targets. You're going to learn how to calculate what's called the loading dose by knowing the volume of distribution and the target plasma concentration that you need to attain. Likewise, you will be able to rearrange the same equation to calculate the volume of distribution if you know the drug concentration and you know the dose that was administered to that patient. You will also be able to calculate the maintenance dose, which is a very important target. This is by knowing the clearance and the desired concentration that you want to maintain, drug concentration that you want to maintain in plasma. If you know the volume of distribution and the elimination rate constant, you'll be able to calculate the drug clearance. You can rearrange the same equation to calculate the elimination rate constant by knowing the volume of distribution and the clearance. And there is a constant relationship between the elimination rate constant and the T-half. So you'll know that equation and you'll be able to calculate each of them from the other. And last but not least, of course, you're going to be able to interpret the T-half, make some clinical interpretations based on knowing the T-half, and you're going to be able to find the relationship between the different pharmacokinetic parameters. Although we have a big list of objectives, yet we can summarize all these objectives into four equations: the maintenance dose equation, the loading dose equation, the relation between the T-half and the elimination rate constant, and the relation between the clearance, the volume of distribution, and the elimination rate constant. So it is basically four equations that we are going to move around or going to play around with, perhaps rearranging one of them so we can get a different kinetic parameter each time with different rearrangement of the equation. So in kinetics, very frequently you see abbreviations, and there are many abbreviations, but these easy ones that you see here are the ones that you should know, where C stands for the concentration, Cmax stands for the maximum concentration, and we usually want to know that when we want to calculate the volume of distribution, or perhaps we want to calculate this maximum or attainable concentration if we know the volume of distribution and the dose. The steady state, CSS stands for the steady state concentration. Steady state concentration is important to decide about when we want to calculate the maintenance dose. CL stands for clearance, and T stands for the time, while tau stands for the dosing interval. And the dosing interval means that perhaps you're going to give the drug every 2 hours, 4 hours, 6 hours, 12 hours, This is called the tau, or the dosing interval. Of course, T half is the half-life, and K is the elimination rate constant, and Vd is the volume of distribution. So in kinetics, it's very important to watch for the units. So for example, in clearance, clearance is expressed as the volume of plasma which is cleared from the drug per unit time. Sometimes it's expressed as ml per minute, like we're expressing glomerular filtration rate, for example, and sometimes it's expressed as liters per hour. Concentration is expressed in milligrams per liter or micrograms per ml, and they are exactly the same thing. If we say milligram per liter, we know that 1 milligram will contain 1000 micrograms and 1 liter will contain 1000 ml. So saying milligrams per liter is exactly the same as saying micrograms per ml. And likewise, saying milligrams per ml is exactly the same as saying grams per liter. A dose usually comes in milligrams or grams, perhaps per day. And again, this is will be the dosing interval. Perhaps it's per day, per 6 hours, or whatever. Dosing rate comes per unit time, perhaps per hour or per minute. And if we express it per minute, sometimes we call it a rate of infusion, for example. Vd stands for the volume of distribution, and it's expressed either in liters or in liters per kg. And there are two advantages of expressing the volume of distribution liters per kg. First of all, you can generalize this to any patient by multiplying by the patient's weight, so you know the total volume of distribution of that drug in that particular patient. Second advantage is it tells you something about the distribution pattern of that drug. If a drug has a volume of distribution of 0.2 liters per kg or 0.2 something liters per kg, this drug is distributed in almost 20 something percent of the patient's volume, the patient's body volume. Which means that this drug is most probably distributed in the extracellular compartment. A small volume of distribution, something like 0.05 liters per kg, will be for drugs that are distributed mainly intravascular. Drugs with larger volume of distribution, like for example 0.5, 0.6, 0.8 liters per kg, probably they enter into the cells. However, if the volume distribution is really large, sometimes we call it apparent volume of distribution because it's not really realistic. Okay, this drug will be hiding in a particular tissue. So it tells you something. If you express the volume of distribution in liters per kg, it tells you something about that drug's distribution. When you determine the clearance of a drug, sometimes you express it as ml per minute or liters per hour. To convert between them, you're going to multiply by 60 over 1000. Okay, when you're converting from ml to liters, you are dividing by 1000, and when converting from minutes to hours, you're going to multiply by 60. So this is to convert from ml per minute to liters per hour. So let's start with the first task. The first task is going to be calculating the loading dose by knowing the volume of distribution and the target plasma concentration. This is not classically what we do. We don't classically give the patient loading dose. However, you know from first order kinetics, drugs that follow first order kinetics, that the drug would require 4 to 5 T halves to reach what we call a steady state concentration. We usually start by a maintenance dose, and we want to maintain this dose for the whole period of therapy. But in order of the drug to attain the steady state plasma concentration that we are aiming at, we need to wait for 4 to 5 T halves. Sometimes we cannot wait, and sometimes the T half of the drug is very long, in which case we will need to give the patient a loading dose. So this is the situation when we give a loading dose. This is not really the classic situation. This is actually the exception. So now we need to understand, as long as we're going now to calculate the loading dose, we need to understand a little bit about the pattern of distribution of drugs. Whenever we give a drug, whether we give it by the oral route or we give it intravenously, the drug is going at the end to reach the circulation. From the circulation, this drug is going to be distributed. Perhaps it's going to be distributed only inside the intravascular compartment, or maybe it will leave the blood vessels and will be distributed extracellularly, or it will be distributed even inside the cells or hide in certain tissues. So some drugs will stay in the intravascular compartment. Some drugs will distribute extracellular, some drugs will enter the cells, some drugs will hide in certain tissues. As you can see, this is the relative volume of the different compartments. It's like the total body water is 2/3 of it is within the intracellular fluid compartment, and only 1/3 is extracellular and inside the blood vessels. Okay, so what happens in real is that the drug might distribute in a mix of these, what we call it a multi-compartmental distribution. So there are no clear-cut numbers. So now we want to know what loading dose to give. We need to find out something called the volume of distribution. Now, what is this volume of distribution? What happens is when a drug is being developed, we give the drug to a healthy volunteer in a certain dose that we know, and after that we take a plasma sample and we estimate the maximum concentration in that plasma sample. And the volume of distribution will be the numerical relation that we get, or the number that we get by dividing the dose by the plasma concentration that we estimate. So it doesn't have to be something real. It really means nothing. It might not mean something in real life. It is simply what we get by dividing the dose that we gave to the patient by the plasma concentration that we estimated. So, and we call this the volume of distribution. And why do I say this? Because sometimes you give, let's say, a big dose to the patient, a dose of 100 milligrams, 1 gram, whatever. And then you take a plasma sample and you find a very, very, very low plasma concentration. What happened to the drug? Perhaps the drug went and was concentrated in cardiac muscle, or in the adipose tissue, or in the bone, so you don't see it in plasma. So in such case, when you divide the dose by the concentration, you get a very big number. If you're going to divide this by the patient weight or express it in liters per kg, maybe you will find the volume of distribution to be 2 liters per kg, 3 liters per kg. This is not something realistic. It is not something that anyone can understand. So the volume distribution, we call it hypothetical. We call it apparent. It is simply a number. It is not something, it doesn't have to be something real. It is simply the relation between the dose that we have given to the volunteer or to the person and the plasma concentration that we got in plasma. So now we can use this to calculate the loading dose by simply rearranging the equation. So we get the loading dose by, if we find the volume of distribution and we know the plasma concentration that we want to reach, or we want to achieve, or we want to attain, we multiply this concentration by the volume of distribution, and here we get the loading dose that we want to give to a patient. Now we take this example. If we need to give digoxin to a patient with heart failure and atrial fibrillation, and we want to reach a target plasma concentration of 1 microgram per liter, and we know the VD of digoxin is 7 liters per kg and the weight of the patient is 60 kgs, so what will be the required loading dose? So first of all, why specially load digoxin? Because digoxin is given for heart failure and atrial fibrillation. If this patient is in critical situation, we want this drug to attain its desired level quickly. Type, we can give the maintenance dose and wait, but we need to wait for 4 to 5 T-halves, and the T-half of digoxin is around 1.5 days, so which means that we are going to wait for a week for the digoxin to reach its steady state concentration, which sometimes is not practical. That's why we need to give loading. So to calculate the loading dose, we are going to use the equation loading dose equals volume of distribution times the concentration. But what is the volume of distribution? Here we have it in kgs. We need to multiply this by the patient's weight. So we need to multiply 70 times 60 to 7 times 60 to get the volume of distribution in that particular patient. Of course, you can see that the VD of digoxin is 7 liters per kg, which is again not something that anyone can understand. This is what we call hypothetical or apparent volume of distribution because digoxin, it hides in certain tissues and you get a very small plasma concentration after you give your dose. So first step will be to calculate the volume of distribution in that particular patient. It will be 60 kgs times 7 liters per kg. This will give us 420 liters, which is the total volume of distribution of digoxin in that particular patient. Now, what do we need to do to calculate the loading dose? We need to multiply this VD by the desired plasma concentration, which is 1 microgram per liter. As you notice here, the concentration comes in liter. Sometimes it might come in per ml. We would say, for example, 1 nanogram per ml. It will be exactly the same as 1 microgram per liter. So we're going to multiply 1 times 420. We get 420 micrograms. This is the dose that we are going to need. But here comes another small problem. You don't have 420 tablets in the market. You cannot always design the size of the tablet exactly as you want it. These are tablets, they are ready-made. So you have the 125 microgram tablet, you have 250 microgram tablet, but it looks like both of them are too small for your dose. You can give 2 tablets of 250 micrograms, but this is going to be a very big dose because the dose you need is only 420. So perhaps you can combine a 250 microgram tablet with 125 microgram tablet in order to reach a dose of 375 micrograms, and this will be the most suitable dose from these choices for your patient. Now, next, we can try to calculate the volume of distribution by knowing the drug concentration and the administered dose. We need to rearrange the equation. If we know that the VD equals the dose divided by the plasma concentration, if we have the plasma concentration and we know the dose, now we can calculate the volume of distribution like this example here. This is a 30-year-old 70 kg woman with a serum creatinine clearance of 0.9 milligram per deciliter. An initial gentamicin dose of 140 milligrams was given intravenously. Then we want to estimate the volume of distribution, and we know that the maximum or the peak means maximum concentration attained was estimated to be 8 milligrams per liter. So as you can notice here, we have creatinine level. Do we need that? We don't need that. So we don't need to use, or we don't have to use all the numbers that come into a case. We need to know exactly what are the parameters required for calculating whatever we want to calculate. So here we want to estimate the volume of distribution. We know the dose, and we have estimated, or we know the concentration or the peak concentration. So the volume distribution will be the dose divided by the concentration. So as you can see, this is the loading dose, which equals Vd times concentration. So the Vd would equal the loading dose divided by the concentration, which is 140 milligrams divided by 8 milligrams, which would be 17.5, as you can see, 17.5 liters, 17.5 liters. Now, let's say, why can't we do something extra? Maybe we can divide this total. If we can divide the total volume of distribution, which is 17.5, by the patient's weight, which is 70 kgs, we are going to get something around 0.2 or 0.2 something, which means that this gentamicin is distributed in around 20% of that patient's body weight, which tells us something about the pattern of distribution of gentamicin and the fact that it is distributed in the extracellular compartment. This is another example. Drug is given in 200 milligrams as a single dose, results in peak plasma concentration of 0.04 milligrams per ml. Now, what is the volume of distribution? Now, as you can see, the choices you have are in liters. So perhaps it's nice to maybe you want to convert those milligrams per liter per ml to milligrams per liter. Maybe you want to convert milligrams per ml to milligrams per liter. To do this conversion, you need to you need to multiply by 1000. So 0.04 milligrams per ml multiplied by 1000 will be 40 milligrams per liter, will be 40 milligrams per liter. Okay, so now you can, this will be the concentration expressed in milligrams per liter. Why? Because here we have the volume of distribution expressed in liters. Now we can divide the dose, which is 200, by the 40, and we get an answer of 5. So the most suitable answer here will be 5 liters. Here it says the expected initial plasma concentration of gentamicin after IV injection is 80 of a dose of 80 milligram to a 60 kg female. It's more or less the same female. Knowing the volume of distribution of gentamicin is 0.25 liters per kg, we want to expect the plasma concentration. So we are doing the exact reverse. Here we want to expect, or we want to calculate the concentration by knowing the dose and the volume of distribution. Now, the volume of distribution in that particular patient will be 0.25 or 0.25 liters per kg times her weight, which is 60 kgs. It's going to be 15 liters. So her VD, total VD of gentamicin in that patient is 15 liters. If we want to estimate the concentration, now we are going to divide the dose by the VD. It's going to be 80 over 15. So the expected concentration, we expect a concentration of 5 milligrams per liter. 5 milligrams per liter. Third thing, we can determine the clearance by knowing the volume of distribution and the elimination rate constant. So what is the clearance? Clearance is one of the most important parameters that you will hear about in kinetics. It is the volume of fluid from which a drug is removed per unit time. It might be measured or expressed in ml per minute or in liters per hour. So this is saying, using all the clearance mechanisms, we're not specifying something. Perhaps it's drug is partly cleared by the liver and partly removed by the kidney, but the total clearance of the drug tells us how many mLs or liters of plasma are clear from the drug in 1 unit of time. Let's say it is liters per hour. So it is liters per hour. Remember that we talked about before, or you know from perhaps what you know about kinetics, but something called the first order kinetics. First order kinetics means that you are going to clear, or you're going to metabolize, or you're going to eliminate a fixed percentage of drug per unit time. Fixed percentage of drug per unit time. This is what first order kinetics means. We express this as the K elimination, or the constant of elimination, or the elimination rate constant. So what is the elimination rate constant? It is the percentage of drug removed from the body per unit time. So it's a percentage per unit time. So this percentage per unit time, if we multiply it by the volume of distribution, this drug is distributed in its volume of distribution. So if I'm going to say that this drug is distributed in, let's say, 100 liters. This is the drug's volume of distribution, total volume, it's 100 liters. But my clearance mechanisms can clear 50% of it per unit time. So what's the 50% from the 100 liters? It is 50 liters per hour. So if my elimination rate constant, if my rate of elimination is 50% per hour, and my drug is distributed in 100 liters, I can clear 50% of this 100 liters per hour. So my clearance will be 50 liters per hour. This is the golden relation between the clearance elimination rate constant and the volume of distribution. Again, expressed in another way, the volume of distribution is the volume in which all the drug is distributed. So all the drug is distributed in this volume. Okay, the elimination rate constant is the percentage of the drug removed per unit time. Removed from the VD. So if I'm going to multiply the percentage eliminated per unit time times the whole volume of distribution, I am going to know what percentage of volume, okay, or what volume actually is cleared per unit time, which is actually the clearance. Okay, so I hope you understand that. So again, remember when we said about the first order kinetics, we said that the first percentage of a fixed percentage of drug is eliminated per unit time. We name this fixed percentage as the elimination rate constant, and we denote it by the K constant of elimination. Notation is KEL. Okay, this is a notation for what we call the elimination rate constant, which is the fixed percentage of drug eliminated per unit time. So again and again, if we have a percentage, a fixed percentage to be eliminated per unit time, and this fixed percentage, we're going to apply it to the volume of distribution, which is the whole volume in which the drug is distributed. Okay, so now as if we are saying what percentage of this volume of distribution will be cleared per unit time? What percentage of this volume of distribution will be cleared per unit time? Okay, or what is the actual volume that will be cleared per unit time? It is multiplication of this constant of elimination, the percentage eliminated per unit time, times the volume of distribution. So if we multiply the elimination rate constant by the volume of distribution, we get, if we multiply percentage per hour, we multiply it by liters, which is the unit for the volume of distribution, we get liters per hour. We get liters per hour, which is the unit for clearance. So clearance will be actually the elimination rate constant multiplied by the volume of distribution. So we get an example. A drug has a volume of distribution of 70 liters, elimination rate constant of 0.12 per hour. What does it mean, 0.12 per hour? It means 12% of the drug is eliminated per hour. This is what it means. This is a first order kinetic elimination. Again, we said about first order kinetic elimination, a constant percentage is eliminated per unit time. Now, what's the percentage for this drug? It is 12% per hour. 12% of that drug is eliminated per hour. So if this drug is distributed in 70 liters, how many liters will be cleared per hour? It will be 12% out of the 70 liters. It's as simple as that. The drug is distributed in 70 liters. We will eliminate 12% of it. So it will be 12% of the 70 liters. Okay, so we multiply, okay, and what do we get? If you multiply 70 by 12%, you get, of course, the 8.4. It is not something like 1.7, of course not. Like imagine 12% out of 70, it will be something close to a 10, okay, even without using a calculator. And it will not definitely be 580 liters, because this is not even the unit for clearance. Clearance comes in either ml per minute or liters per hour, so it has to be volume per unit time. Next, we can determine the elimination rate constant by knowing the volume of distribution and the clearance. And again, this is a simple rearrangement of the same equation.
We can also calculate the elimination rate constant of the drug by knowing.
Here's another example. You have the clearance and the volume of distribution of an antibiotic. The clearance is 6 liters per hour, and the volume of distribution is 30 liters. So what is the elimination rate constant? We know that the drug's volume of distribution is 30 liters. Each hour, 6 liters will be cleared. So its total volume of distribution is 30 liters. But we can clear 6 of those 30 liters per hour. So this is the clearance. So what do you think is the elimination rate constant? What percentage is eliminated per unit time? If the whole volume is 30 and I'm able to clear 6 liters per hour, this actually represents 1/5 of the volume of distribution, or 0.2. Now, how did we get this 1/5 or 0.2? This is by dividing 6 liters by 30. So we get 0.2, which is it will be the elimination rate constant. So this is again the equation, which tells us that the elimination rate constant equals the clearance divided by the volume of distribution.
This is our equation.
And if we're going to apply this, we're going to get these answers. And as I told you, if we divide 6 by 30 liters, we get the most appropriate answer will be 0.2 per hour. What's 0.2 per hour? 20% per hour. Sometimes you get it as hour to the power of -1. Sometimes you get it written as hours to the power of -1, and sometimes you get it as per hour, just as it's written here. So next we'll be performing interpretations based on knowing the T-half in first order kinetics. If we know that a drug follows first order kinetics and we know the T-half of the drug, we can expect a lot of things about that drug by knowing the T-half, as we will see. So it is the T-half, it is the time needed for the drug concentration in plasma to drop to its half. It is actually it is the time needed for the whole amount of the drug in the body to decrease to its half. And we expect that the plasma concentration is a reflection of the decrease of the whole amount of drug in the body. So decline by 50%. Okay, how much time does it take? So again, the T half will be the time needed for the drug concentration in plasma to be reduced by 1/2. As I told you again and again, because some people don't really appreciate this or they don't understand it, this is actually a reflection of the whole amount of drug in the body. So when we say T half, we say that, or we expect that half of the total amount of the drug present in the body to drop to its half. And of course, it's a very important parameter. First of all, it happens under first order kinetics. Okay, and second, it's important because it will help us to expect many things about the drug. So what happens when we start the drug by its maintenance dose? What happens is this. Let's say the T half of a drug is 4 hours and we start giving the drug in 100 milligrams. After 4 hours, the 50 milligrams of the drug will still remain in that patient's body. And then let's say we decide that we are going to repeat dosing exactly at exactly the T halves of the drug. So we are going to give a drug dose and we keep the dosing interval the same as the T half, because this is not, by the way, exactly what happens in real life. You don't have to keep the dosing interval exactly as the T half. It doesn't have to be like that. But this is what we are going to do in this example. So after the first T half, we repeat the dose. Now we have 50 milligrams remaining in the body from the first dose, and now we give 100 more, so the level is going to reach 150 milligrams. By the second T half, those 150 milligrams are going to drop to 75, because at the end of the T half, half of the amount of the drug is going to still remain. So we give yet another dose. Now the amount reaches 175. This is the third dose that we have given. Two T halves have elapsed now. Now this is with the third T half. The drug level is going to drop to 1/2 of the 175. It's going to be around 88. Now we give yet another dose. We are going to be up to 188 remaining from the previous dose. And then we are going to find that by that time, by the lapse of 4 or 5 T halves, the very first dose that we have given has almost gone. It has been totally eliminated. And each dose that we are giving is going to replace one of the previous doses. So it's like one dose is being completely eliminated and a new dose is being given. So it's in equals out, and we reach what's called the steady state concentration. Interesting enough, if a drug follows first order kinetics, it doesn't matter the dosing interval that you are using. You might be dosing the drug constantly every 8 hours, every 12 hours, every 2 hours, even giving it by intravenous infusion. It doesn't matter which rate of administration you are using. You will reach steady state concentration after 4 to 5 T halves, because after 4 to 5 T halves, the very first dose that you have given has been completely eliminated, and it's being constantly replaced by new doses that you are giving. This, of course, is provided that you don't reach zero order kinetics and you don't reach accumulation. You're not giving toxic doses that are going to accumulate in the patient's body. So from the T-half, we can determine when a steady state concentration is going to be reached. You simply multiply the T-half by 4 or 5, and this is the time when you are going to reach the steady state concentration. So let's see this very simple example here. A half-life of a drug is about 12 hours. How long will it take for blood level of a drug to reach a steady state concentration? You simply multiply by 4 and you look into the answers that that are in front of you. You have 2 days. 12 hours times 4 is going to be 48, which is basically 2 days. So perhaps this is the answer. 4 days, 8 days, 12 days, these are not suitable answers, so 2 days is the correct answer. A patient on digoxin therapy has developed digitalis toxicity. Of course, you know the therapeutic plasma level is something between 1 and 2 micrograms per liter or nanograms per ml. Here the concentration has reached 4 nanograms per ml. This is a toxic concentration. Perhaps the patient now has arrhythmia. Patient now perhaps has a severe heart block. Or perhaps ventricular tachycardia, signs of digitalis toxicity. So how long if we stop digoxin now, how long is it going to take the drug level to reach 1 nanogram per ml, which is actually the therapeutic level that we want to reach? So from 4 to reach its half, 2. So for 4 nanograms per ml to become 2 nanograms per ml, it will need 1 T-half. Okay, so this is the T-half of digoxin is 1.6 days. And then from 2 nanograms per ml, for those 2 nanograms to go down to 1 nanogram per ml, it's going to be another T-half. So we are going to need 2 T-halves for the 4 to drop to 2 and 2 to drop to 1. So we're going to need 2 T-halves. So the correct answer here is going to be 3.2 days, which is quite a long time. You cannot wait and leave the patient all this time. That's why we might use digitalis antibodies to neutralize digoxin if the patient is getting severe toxicity, because 3.2 days is a very long time to wait.
The plasma concentration of 4 nanograms.
Now we need to know how to calculate the T-half based on the elimination rate constant. So this slide summarizes the relationship between the T-half and the elimination rate constant, and there is an inverse relation between them. So they are related by a constant. So the longer the T-half, the longer the T-half, the smaller is the elimination rate constant. Let's say if the elimination rate constant is 10%, and for another drug elimination rate constant is 50%, of course the drug with the elimination rate constant of 50% is going to have a much shorter T-half, because 50% of the drug will be eliminated per unit time. However, elimination rate constant of 10% per hour, for that drug, the T half is going to be much longer. So there is an inverse relation, and they are related by a constant. The constant is 0.693. Now, what does this constant mean? This is actually the elimination rate constant. It is the K of elimination or constant of elimination if the T half equals 1 hour. So if we say that a drug has a T half of 1 hour, it means that its elimination rate constant is a 0.693. Or a drug has to have an elimination rate constant of almost 70% to have a T half of 1 hour. I know this might not be very much understandable, but I can explain it more in later sessions for those who are deeply interested in kinetics at a higher level. So if we know that the elimination rate constant of a drug is 0.11 per hour, or 11% per hour actually, so what will be the T half of that drug? So remember the constant is 0.693, so we divide 0.693 by 0.11. So what do you think will be the answer? It will be something close to 6 hours. Okay, you don't even need a calculator for this, so the correct answer will be 6 hours. Now, how can we calculate the maintenance dose? It comes late, however, this is actually the most important equation among all equations. And you know why? Because this is the one that you are going to need every day in your practice. Because every day you are calculating maintenance doses. So actually, this is the most important equation that you should know about. So to be able to calculate the maintenance dose, you need to know the clearance and the steady state you want to maintain, and then you need to know the dosing interval. Let me explain this more. Let's say that you want to maintain a certain steady state concentration of, let's say, 1 milligram per liter. This is the steady state that you want to maintain. So you want to maintain a steady state concentration of 1 milligram per liter. But what if you know that your body is capable of clearing 5 liters per minute? So you want to maintain a steady state of 5, or let's say 5 liters per hour. Any number, it will not matter. Let's say your body is capable of clearing 5 liters of plasma per hour. And you want to maintain a concentration of 1 milligram per liter. In 1 hour, 5 of those liters, 5 liters have been cleared. Each liter of the cleared liters contains 1 milligram. So you need 5 milligrams per hour. If I want to calculate this dose for a larger dosing interval, let's say 6 hours, I'm going to multiply the 5 milligrams per hour times 6 to be, and I say I need 30 milligrams every 6 hours. If I'm going to multiply it to calculate a daily dose, I'm going to multiply the dose needed per hour by 24 hours in a day. So this is the principle, and we're going to see examples. So perhaps you need to infuse a drug to maintain a concentration of 2 milligrams per liter. So this is the concentration that you need to maintain, 2 milligrams per liter. You need the concentration to be maintained at 2 milligrams per liter. This drug is extensively cleared by the kidneys. Okay, it's cleared just like creatinine, and its clearance is going to be 100 ml per minute. So how many liters are these 100 ml per minute? This is 0.1 liters per minute. 0.1 liters per minute. So these kidneys are clearing 0.1 liters per minute. You want to maintain a concentration of 2 milligrams per liter. Each minute you are clearing 0.1 liters, or you are losing 0.1 times 2 milligrams per liter. Okay, so each minute you are losing 0.2 milligrams. So if you are going to infuse that drug, you need to infuse it at a rate of 0.2 milligrams per minute. Let's see the calculation. So the infusion rate should equal the clearance times the steady state concentration. 100, okay, is the clearance, times 2 milligrams per liter, okay, but then these 100 ml per minute, so we need to divide by 1000 to convert the units. So you will need 0.2 milligrams per minute. You need 0.2 milligrams per minute because each milliliter you needed to contain 2 milligrams. Each liter you needed to contain 2 milligrams, and you are losing 1/10 of this amount by clearing 0.1 liter per minute. So you need to infuse this drug at a rate of 20 micrograms per minute. This is another example. It is desired to maintain a plasma concentration of 0.15 grams per liter of an antibiotic. Plasma clearance is 8.82 liters per hour. What will be the infusion rate? These numbers here are slightly different. I have made them easier. Instead of the 8.8 something, I've just made it 9 liters per hour. So what do you think the answer will be? The closest answer, or the answer which is closest to the correct answer will be multiplying. We know that this is the maintenance concentration, or this is the steady state concentration that we want to maintain, 0.15 grams per liter, but the clearance is 9 liters per hour, so we are clearing 9 liters each hour. Each liter of these 9 liters that we are clearing contains 0.15 grams, so we multiply the 0.15 grams by 9 liters and we get 1.35 grams per hour. This will be our maintenance dose. This is another example. This is a 50 kg woman is given an anticonvulsant drug. We need to calculate a daily dose this time, and we may need to maintain a concentration of 6 milligrams per liter. We need to maintain a concentration of 6 milligrams per liter, and we have the clearance, which is 0.06 liters per kg per hour. We need to multiply this by the patient's weight. Patient's weight is 50 kgs, so 0.06 times 50, it will be 3 liters per hour, because 0.06 multiplied by 50 will be 3. Then we multiply this by 6 milligrams per liter, which is the concentration. So we are going to need 18 milligrams per hour. But one day has 24 hours. So if we multiply 18 times 24 hours, we get 432 milligrams per day. Again, you don't have 432 milligram tablets. So perhaps in the market, you have 200 milligram tablets. In this case, you can give her 2 tablets per day, and it will be the closest dose that you can give to that patient. Then we need to relate all the kinetic parameters to each other because they are all interrelated. So we can revise. This is the loading dose. This is the maintenance dose, which equals the clearance times steady state concentration times, of course, the dosing interval. Okay, if we don't need it as an infusion. Okay, as you can see, Then there is the relation between the clearance and the elimination rate constant and the volume of distribution.
Also,
So let's see this example. The clearance and volume of distribution of tobramycin, which is an antibiotic, is 5 liters per hour and 40 liters respectively. So 40 liters is the volume of distribution and 5 liters per hour is the clearance. What is the maintenance dose to be given intravenously to obtain a steady state concentration of 4 milligrams per liter? So to obtain a maintenance dose, we need to multiply the steady state concentration by the clearance. Okay, so we multiply the steady state concentration by the clearance. Okay, and if we want to give it every 6 hours, then we multiply it by the dosing interval. So this is going to be simply 4 liters per hour times 4 milligrams per liter times 6 hours. So it will be 120 milligrams every 6 hours. If we have some choices, of course, as you know, we choose the closest one. This is another example. Normal volunteer with receiving a new drug in phase 1 trial. The clearance and volume of distribution are 1.386 liters per hour. This is the clearance, and 80 liters. This is the volume of distribution. Now here we want to calculate the T-half. Now, we know that clearance equals the volume of distribution times the elimination rate constant. So we can use the clearance and the volume of distribution to calculate the elimination rate constant, and from that we can calculate the T-half because we know there is a constant relation between the T-half and the elimination rate constant. Okay. So as you can see, we're going to divide the clearance by the volume of distribution, and as you can see here, the units for the clearance are liters per hour, and if we divide them by 80 liters, liters cross out, they cross each other's out, so the unit for the elimination rate constant will be per hour, or hour to the power of -1, and here the elimination rate constant will be 0.017. Now what does this mean? It means that 1.7% of this drug is cleared per unit time or is cleared per hour. So what do you expect about the T-half? Is this going to be a long or a short T-half? Because this is a very, very small value for elimination rate constant, it means the T-half is going to be quite long. So if we're going to divide 0.693 by the elimination rate constant that we have, we get a T-half of more than 40 hours. So by now, I think we have achieved all our goals, and I hope you found the pharmacokinetics easy, and thank you for your listening.